topic for today's class is drug therapy of neurodegenerative disorders. Now these neuronal degenerative disorders, the important common one are Parkinsonism and Alzheimer's disease. Now we're going to learn about the drug therapy of anti-Parkinsonian drugs and also about the drugs used in Alzheimer's disease. So the objective for today's class is that at the end you should be able to classify the drugs used in Parkinson's disease and should be able to describe the mechanism of action, types, doses, side effects, indication and contraindication of the drugs used in neurodegenerative disorders. Now what Parkinson's disease is? What happens in Parkinson's disease is there is neurons, dopaminergic neurons get degenerated. Now what happens because of degeneration of the dopaminergic neurons, an imbalance occurs between the dopamine activity and the acetylcholine activity. There is increase in acetylcholine activity and decrease in dopaminergic activity, which is seen as symptoms like mask-like faces, stooped posture, tremor, pill rolling tremors, difficulty in movement. So all these are the symptoms of Parkinson's. So the most important symptoms of Parkinson's disease is hypokinesia, rigidity and tremors. Now what happens here is there is a progressive and irreversible degeneration of the dopaminergic neurons in the substantia nigra pars compacta. Here these dopaminergic neurons get degenerated and therefore the imbalance occurs between dopaminergic and cholinergic activity. Now there are many causes which can lead to this Parkinson's disease like aging, environmental toxins like MPTP, excess of excitatory neurotransmitters, or could be some genetic causes. Now the mainly these anti-Parkinsonian drugs are classified as drugs which are affecting the brain dopaminergic system, which increases the dopaminergic activity. Now this includes dopamine precursors like Levodopa, a very important class of this group, Levodopa. Then there is a peripheral decarboxylase inhibitors like carbidopa, benzerazide. Then the dopamine agonist, which acts directly on the dopamine receptors, bromocriptine, ropinirole, pramipixole and rotigotine. Then MAO-B inhibitors, which decreases the degradation of the dopamine like salicyline and resazoline. COMT inhibitors again increases the dopamine level by inhibiting its metabolism. Intracapone, tolcapone. Glutamate antagonist or dopamine facilitator, amantadine, and there are certain newer drugs like safinamide, estradiol and opicapone has been recently introduced. Then there is another class of drug which are the drugs affecting the brain cholinergic system, which will be decreasing the cholinergic activity. So these are central anticholinergics like trihexyphenidyl, procyclidine and piperidine. And then there is antihistaminics like orfenadrine and promethazine. So let's begin first with the Levodopa, a most important class of this group, Levodopa. Now this is a highly effective and remains as a gold standard treatment in treatment of Parkinson's disease. As such, dopamine cannot cross the blood-brain barrier. This is a blood-brain barrier and you can see dopamine cannot cross the blood-brain barrier. So Levodopa is a prodrug form of the dopamine which can cross the blood-brain barrier. But in spite of crossing the blood-brain barrier, only 2 to 3% will be able to reach the brain. Because most of it get peripherally because of dopa decarboxylase enzyme get metabolized peripherally to dopamine and can lead to peripheral side effects. So to increase its penetration in the brain, levodopa is always combined with carbidopa or benserazide. Now what does this carbidopa and benserazide do is they inhibit the dopa decarboxylase and they increase the penetration of levodopa. So around 10% of the levodopa can penetrate the blood-brain barrier and reach to its site. In the brain, it improves the rigidity and hypokinesia, but there is a later improvement of the tremor or a little improvement of the tremors. But the main symptoms which get improved is rigidity and hypokinesia, and there is general alerting effect, their speech, their mask-like faces, their involvement in general activity will be increasing after giving the levodopa. But the dementia component will not be improved by giving levodopa. In the cardiovascular system, it may cause tachycardia because of the beta-1 stimulation. It may cause tachycardia. Endocrine, it may inhibits the prolactin release. Again, by acting on the dopamine receptors, it can inhibit the prolactin release. In CTZ center, stimulation of the dopamine receptor can result in nausea and vomiting, and to control this nausea and vomiting, either you have to give the divided doses of levodopa or you need to give domperidone but not metoclopramide. Now the most important pharmacokinetic of this group is gastric acid and protein rich food. It decreases the bioavailability of dopamine. So you need to remember that with gastric acid and protein rich food should be avoided while giving the levodopa. Metabolized in liver and half-life is 1 to 2 hours and it gets excreted in urine. Now vitamin B6 or pyridoxine increases its peripheral metabolism because pyridoxine is the cofactor for dopa decarboxylase enzyme and it may increase its peripheral metabolism. Now what are the main adverse effects associated with this is you have to be careful. It may cause nausea and vomiting, can be inhibited by giving domperidone. Postural hypotension can occur. Postural hypotension is again a central effect because of increasing dopaminergic and sympathetic neurotransmitters in the brain. It may lead to decrease in the release of the sympathetic activity, decrease in the release of adrenergic neurons, adrenaline, noradrenaline release will be decreased and it may lead to postural hypotension. But gradually this symptoms, this side effect, the tolerance will occur to this side effect. Then there could be arrhythmias or hypertension can occur because of adrenergic receptor stimulation, beta-1 and all alpha-1. It may cause arrhythmia and hypertension, and this will be more if you are giving it with the drugs like MAO-B inhibitors and these drugs, it will be more. Then there could be taste abnormality. In CNS, behavioral psychotic effects may occur because of increase in the dopaminergic activity. There could be agitation, anxiety and all this. Behavioral psychotic hallucination, all these side effects may occur. Then dopamine dysregulation syndrome can also occur, in which the patient may have tendency to take more of the levodopa or more of the drug. And then punding, that is choreoformic like a movement can occur in the patients because of the increase in dopaminergic activity. Then there is dyskinesia, that is dyskinesia occurs after chronic therapy of levodopa. Dyskinesia can occur. Now dyskinesia is again there is tick-like movement and patient becomes, there is restlessness and all this will occur in the dyskinesia. This is again because of increase in dopaminergic activity after the chronic therapy is given, dyskinesia may occur. Now fluctuation of response can also be there because of the short half-life. On and off phenomena can be seen. On is when there is no symptoms of Parkinsonism is seen, and off is when there is again the symptoms start appearing. It is known as off phenomena, or the wearing off effect can be seen, and this wearing off effect or off phenomena can be inhibited by giving carbidopa or by adding the other drugs like COMT inhibitors or MAO-B inhibitors. Then you should never withdraw it suddenly, because abrupt withdrawal may precipitate this neurolap malignant syndrome. There could be hyperthermia and all this may occur. This is known as neurolap malignant syndrome, which may occur. Because of that, abrupt withdrawal of levodopa should never be done. Then again, mydriasis because of alpha-1 stimulation in the eye. So you have to be careful, especially in patients of glaucoma. Then brownish discoloration of saliva, urine, hot flushes, and it may cause positive Coombs test. So you have to be careful with all the side effects it may cause. Now these are the peripheral side effects like nausea, vomiting, postural hypotension, arrhythmia and all. They can be inhibited by adding carbidopa. But the central side effects like behavioral, dopamine dysregulation, punding, dyskinesia, this cannot be controlled by giving carbidopa alone. Then there is drug interaction. Drug interactions can be there with pyridoxine. You have to be very careful with pyridoxine, because pyridoxine can increase the metabolism and can decrease the efficacy of levodopa and increase the side effects. MAO-A inhibitors can cause hypertensive crisis if given with levodopa. Then levodopa if given with metoclopramide, which is again a dopamine blocker, D2 blocker, it may precipitate Parkinson's disease. Now when you give an antihypertensive, you have to be careful that antihypertensives can increase the chances of postural hypotension, or these antihypertensives effect may be decreased because of increase in sympathetic activity by these levodopa. So you have to be cautious especially in active peptic ulcer disease, because it increases the gastric acidity. Malignant melanoma because it is a melanin congener, so you have to be careful. Glaucoma again can be precipitated while giving levodopa. This hyperuricemia, so you have to be careful in gout and ischemic heart disease, as it may lead to arrhythmias. Now there are new formulation to reduce the wearing off effects. So there are extended release capsule. Rytary is available, or dopa is available with carbidopa plus levodopa as intestinal gel. So to decrease the side effect or the wearing off effect of the levodopa. Now another first line therapy is dopamine receptor agonist. This is again a first line therapy in Parkinson's disease. They directly act on D1 and D2 in the corpus striatum. So where is the neuronal degeneration of dopaminergic neurons is seen. Now D2 is inhibitory action. There are two types of dopaminergic receptors, D1 and D2. D2 is inhibitory, D1 is excitatory. D1 and D5 and D2, D3 and D4 are of inhibitory in nature. So what are the advantages of dopamine receptor agonists compared to the other drugs of this group? That is, they are more selective action because they directly act on these receptors, and so therefore less side effect is seen. There is longer duration of action will be seen, and because of that there is less on and off effect of Parkinson's disease as seen in levodopa. Effect does not depend on functional integrity of the neurons, because it does not causes the release of dopamine or etc. It directly act on the receptor. There is less likely to generate free radicals which get degenerated during dopamine formation or dopamine metabolism. there is no need to convert to dopamine. So these all things are not there. It is directly acting on the receptors and longer duration of action is there. So it is considered as a first line therapy in this. There are of two types, like ergot derivatives and non-ergot derivatives. In ergot derivatives, you have this bromocriptine, lyseride, pergolide and cabergoline. In non-ergot derivatives, you have ropinirole, pramipexole, apomorphine and pyribedyl. Now, apomorphine is highly emetogenic. It is highly nauseating drug, apomorphine, but it is used as a rescue therapy for the treatment of off episodes in Parkinson's disease. So it is mainly introduced to treat the off episodes in Parkinson's disease. Now compared to ergot derivatives, now the non-ergot derivatives are mainly preferred, because ergot derivatives, there is a tendency that there are more vasospasm, gangrene, erythromelalgia and fibrosis, cardiac, peritoneal. So all these fibrosis will be more with ergot derivatives. So nowadays non-ergot derivatives are used. Ropinirole is mainly used and have been approved for restless leg syndrome. It can be used as monotherapy, these non-ergot derivatives, in Parkinsonism, or can be added with levodopa and carbidopa. Non-ergot derivatives is now considered as the first choice drug because of the less side effects. So what are the adverse effects? The similar GI adverse effects as seen with levodopa: nausea, vomiting, dyspepsia, reflux, esophagitis, cardiovascular, postural hypotension, painless digital vasospasm, especially with ergot derivatives, arrhythmias, and in central CNS, confusion, hallucination, delirium. These are all the compulsive gabbling. So this is the impulse control disorders. That is the main thing to be concerned in case of these direct dopamine receptor agonist. In ergot derivatives, you have other side effects are also there, like nasal congestion, pulmonary infiltrates, retroperitoneal fibrosis, erythromelalgia, all these. So because of that, it is now not considered contraindicated in psychosis, myocardial infarction, peripheral vascular disease, and again active peptic ulcer. Thank you.